Shining a Light on a Hidden Problem was the title that I was aware of. And the interesting thing is, why is it a hidden problem? It's been around, wounds, and wounds, chronic wounds of the leg have been around for centuries, almost since the beginning of time. So why, if it's been around for a long time, we don't have a better handle on how to manage patients with this problem? And it was well known in the Middle Ages that a well-known academic named Paracelsus, that he dressed the wound, but God healed it. Unfortunately, that is still a prevailing attitude from many of my colleagues and many of your colleagues, those who work in clinical settings today. And one of the things that we need to get away from is the fact that a wound is not a wound is not a wound. What we have to do, as we do in other clinical problems, is why has this patient got the problem? We need to work up that patient in terms of appropriate assessment and diagnostic tools, and recognizing that you come up with the right diagnosis, you've got a much better chance of offering the right treatment. The difficulty is many people believe you can't do anything to wounds. They'll do their own thing. They're frustrating little critters. But the important thing that many people in this room and many people elsewhere in the UK have actually shown you can make a huge difference. Whether it's venous disease, whether it's diabetic foot disease, whether it's pressure injury, whether it's complex surgical wounds. And one of the things that we need to do is to raise the profile of this subject. We need to collect data, not only local data, but regional data and national and nationwide data, to look at the numbers and costs. Other people will speak about this afternoon. We need to move the clinical profile from being something you're wasting your time or your career's over if you end up doing something with wounds. Stop it being a Cinderella specialty or a hidden problem we don't talk about. We need to recognize there needs to be an academic underpinning to the whole issue of wounds. The complex biology of wound healing has often been likened to the biology of cancer. Lots of complicated things happening and interacting with each other. And they're not going to be solved by putting a dressing on the cancer. Neither will leg ulcers be solved by putting dressings on there without actually recognizing we have to have a diagnosis, we have to have a treatment plan, we have to have an appropriate outcome. We also need to recognize that in the world of which we live and the world in which the NHS operates, is we need to have an academic, a clinical, but also a commercial eye on what's going on, to try and convince people who are running businesses, even if they are for-profit businesses, that there's an opportunity for being successful if you focus on wounds. Not just antibiotics, not just antidepressants, not just antihypertensives. Lots of companies can make lots of money, and that's the thing that gels it all together in terms of innovation. We need to look at roles, the fact that it is not somebody else's responsibility, it's all of our responsibility to approach a patient with a wound and bring our own skills and abilities to offering good care for that patient. We need to recognize that the interventions we offer start with dressings but don't end with dressings. Dressings are vitally important, but so are devices, so are drugs, so are surgical approaches, and potentially so are biologically active agents that restore the aberrations in that wound healing cascade. We need to look at outcomes. If I'm an oncologist, if I'm a rheumatologist, you don't measure my success by people I've cured of cancer or I've cured of rheumatoid arthritis. It's about improving their quality of life for the remaining weeks or months of their life if they're oncological patients, and it's maintaining activities of daily living if I'm a rheumatologist, where the disease is there, I can't cure it, but I can stop it interfering with the patient. As we solve the problem, which hopefully we will probably after my lifetime, we will appreciate that once we've healed them, we have to prevent these wounds coming back again. Secondary prevention, influence scarring, and ultimately, some of us who have a dream, maybe it's about looking at primary prevention. We know that a number of factors that increase the risk of these chronic wounds, but we don't have interventions or systems that allow us to offer those to patients early on before they've got a wound or an ulcer. So the future, as I see it, we should have the right patient seeing the individual clinician at the right time, at the right place. One of the things I see in travelling around the world is more and more healthcare is provided out of hospital. This is a condition that can and should, in many situations, be managed out of hospital. We need to be able to prescribe the right intervention using the principles of precision medicine. We need to have the right outcome. Could be healing, could be reduction of symptoms, could get rid of leakage or smell, it could be preventing recurrence. And the other thing that's also important, which underpins all of the things that I and others I suspect will say, is you have to have a team approach. None of us as individuals representing a particular profession are able to manage all of the aspects of chronic wounds and leg ulcers on our own. We have to create a team approach. And that's where I see the opportunities for us to make a difference as we go forward. Thank you for your time.